So welcome to part two of the main ions that we check for, often part of the kidney function. Today we're talking about sodium testing. We've covered potassium testing in part one of this video. So sodium is a really important ion, and I'm going to encourage you to think, whenever you think sodium, that we're often thinking about the water balance of the body. Sodium chloride, as you probably know, is common table salt. Ions carry with them something called an osmotic potential. The easiest way to think about this is making a mixed drink. So if you take a glass of water and then you add some squash to it, you can imagine that is adding the sodium ions. Now, if you add other juices to it, other squashes, other cordials, that is essentially what your blood is like, a mixture of different ingredients. If you were to take that juice mix, pop it into a container which has a membrane down the middle, and on the one side you have pure water, and on this side you've got your juice drink, and the membrane allows for water movement. Gradually, there will be a movement of water across, drawn in by all that extra juice and all that extra cordial to balance out the concentration of water on both sides. So that's called your osmolality or osmotic potential. So sodium is mainly kept outside of your cell, not inside of your cell, like potassium is. And so is a major constituent of your plasma's osmolarity, of its thickness. Firstly, I'm going to cover what causes hypernatremia. So when you have very high levels of salt, almost always that leads to the blood being thicker or generally saltier. So if you're pouring a lot more cordial in, it will make that drink stronger in its osmotic potential because it's one of the major osmolar components. So you don't normally have to question if it's changed the kind of thickness or water driving in potential. It's almost always what we call hypertonic. So the next thing you can think about really is what has happened to the water state of that person. So they have thickened plasma, lots of things dissolved into it. Are they now overloaded with water, which is a clinical assessment that you make? Do they look very dehydrated, or do they actually look neither overloaded or dehydrated? So if you appear to have lots of water, you're overloaded with water and you're overloaded with salt, then the main issues here might be an excess amount of salt intake, such as taking salt tablets, which are sometimes given to people. You may have been given strong salt solution intravenously. We call it hypertonic sodium. And then there are some rarer conditions to do with abnormal hormone levels. So Cushing's and aldosterone levels in excess can bring in extra water and extra salt. If you're low on water and high on salt, so you look to be dehydrated, but you have this high salt level, then the question is what's happening to the salt in the kidneys. So if you have a lot of salt in the kidneys, a lot of salt in the blood and in the kidneys, you also are releasing a lot of salt. You're getting rid of a lot of salt. Then you might be losing a lot of water from diuretics such as loop diuretics or other type of diuretics, water pills like osmotic diuretics. If your kidneys are doing their best to retain the salt, despite the fact that you have got high levels in your blood, and you're dehydrated, then it's possible that you are losing water from somewhere else. So the kidneys are trying to bring back water, and they're doing that by retaining the salt. That probably means you're losing water elsewhere through burns and diarrhea and sweating. And that's why your blood is salty, because it's dry and dehydrated. If you don't seem to have too much or too little water, so you're so-called euvolemic, then you might just be losing a lot of pure water from the kidneys. These are kind of conditions like diabetes insipidus, or you might be losing a small amount of water from somewhere else, like you breathe out a small amount of water. Okay, so that is too much sodium. If you have too little sodium, hyponatremia, the first thing we have to work out is that true and accurate? So here we have to think a bit more about what's called the osmolarity, how much other things are dissolved in your blood. If you have very thick blood, despite there being very little sodium in there, then something else is making it super thick. And the common things might be having really high sugar levels, maybe very high alcohol levels, and there are some drugs that we use as well, things like mannitol, that can make your blood extra thickened and look like your salt levels are relatively diluted despite that blood being thick. If you have a low salt and you have a normal, because you'd think that a low salt being the main ingredient that makes the blood thick, that makes the osmolarity high, if it's normal, the question is there something that's messing around with the reading? If you had a huge amount of fat or cholesterol or triglycerides, fats in your blood, so now you're imagining this drink which I've filled with a normal concentration of the cordial, and I've put in a normal matching amount of water, but I've now filled up half of the cup with fat. If I tested the bottom component where the water and the cordial is, the concentrations are normal. But when you compare the concentration to the overall volume, which contains all that extra fat, it looks like the sodium levels are low, even though the liquid part, the water part, not the fat part, has a normal concentration of ions. So that can confusingly make it look like your sodium is abnormal when actually in the plasma it's okay. If your sodium is low, most of the time, because the sodium is the main dissolved thing that gives the water its osmolarity, you should be hypotonic. You should have a low osmolarity. And then you do the same thing as you would do with hypernatremia. You look at where the water's going. Is this person full of water? Do they look dehydrated, or do they look to be on a normal level, adequately hydrated? So if they look like they are full of water, but they're losing their sodium, conditions that could do that are things like heart failure, liver disease, and kidney diseases, things like nephrotic syndrome, where that can pull in water despite the fact you're losing your sodium out. If you are very dehydrated and you're losing salt, the question is, where are you losing that salt from? If you are losing that from the kidneys, that could be through drugs. So that could be water pills, ACE inhibitors. If your kidneys are doing their best to retain the sodium, then you're probably losing that sodium from somewhere else, diarrhea and vomiting, for example. What if you have a low sodium and you are appearing to have normal hydration status? There are some unusual conditions that can pull in a bit of water slowly and gradually over time, such as inappropriate ADH. If you're drinking a little bit of excess water yourself, and some types of steroid deficiencies. So appreciate that the coverage of this is a bit more challenging, and I'm not expecting people to sit at home and start drawing out diagrams, but it gives you an idea about the processes you need to go down if you're thinking about abnormal electrolytes. Overall, across both these videos, what is most common? Most commonly, people have kidney problems, kidney failure from infections, maybe a new medication, and it might be dehydration. Those are by far and away the most common causes of any electrolyte disturbance. But if you've got a persistent abnormal electrolyte that's being found again and again, then it probably does need a bit more further workup to understand if it could be one of these more uncommon hormone issues, uncommon primary renal problems, or something else. So I hope that it's been okay to follow the videos on hypo and hyperkalemia, hypo and hypernatremia. I hope it's given some insight into this. If you have further questions or comments, please do feel free to leave them below. Thank you.